Welcome back to the deep dive. Today we are plunging straight into, well, a really heavy and critically important section of clinical knowledge. But we have a specific mission here, to give you the clearest, most actionable synthesis of neurologic patient management.
Right.
This isn't just a review, it's a distillation of the high-stakes knowledge found in Chapter 61 of Brunner and Sutter's Medical Surgical Nursing textbook.
That's right. And this content is, it's absolutely foundational for anyone who needs to quickly and confidently manage a patient in neurocritical care. We're going to step by step through 5 core areas.
Okay.
Altered level of consciousness, managing increased intracranial pressure, or ICP, understanding neurosurgical procedures, handling seizure disorders, and addressing complex headache.
And our goal is to make sure you not only know the facts, but really get the implications of the assessment finding.
Exactly. Why a millimeter change in a pupil is a 5-alarm fire.
We're going to walk you through the precise language and, the visual cues, making sure you can differentiate those severe signs, like decortication versus decerebration, and immediately apply critical interventions.
From the second you assess an airway in a comatose patient to the meticulous care needed to maintain cerebral perfusion pressure.
Yeah.
And before we start, let's just frame this. The entire neurologic system is vulnerable on 2 main fronts, and everything else really flows from this.
Okay, what are they?
First, it's structural integrity. This is physical damage from trauma, a stroke, a growing tumor.
Right, the hardware.
Exactly. And second, it relies on this exquisitely perfect homeostatic environment. And that's threatened by metabolic disasters.
Like what?
Like severe sepsis, profound hypoglycemia, DKA, or toxic substances. A critical disruption in either of those areas, structure or environment, rapidly leads to impaired cerebral perfusion, edema, and a potentially catastrophic rise in intracranial pressure.
So we're constantly fighting to protect both the structure and the environment.
All the time.
Okay, let's unpack this by starting with the most basic yet most critical assessment. Altered level of consciousness. In everyday life, we talk about being tired or out of it, but clinically, LOC exists on a strict, observable continuum. What defines that spectrum?
Well, we begin with the state of altered LOC. This is when a patient isn't fully oriented, can't consistently follow commands, or needs, persistent stimuli just to stay alert for a moment.
So loud noises, maybe a little bit of pain.
Exactly. And that's distinct from coma, which is a profound, prolonged state of unarousable unresponsiveness. In a true coma, there is absolutely no purposeful response to internal needs, like hunger or any external stimuli.
But the textbook makes a really interesting point, that a patient can have their eyes open and still be profoundly unresponsive. So we have to get more specific.
Yes, we do. This is where we have to differentiate. Take akinetic mutism, for example. That's an unresponsive state where the patient performs no voluntary movement or speech, but they might sometimes open their eyes spontaneously. They are just silently immobile.
And how is that different from a persistent vegetative state?
So the persistent vegetative state is defined by a return of wakefulness. They often have normal sleep-wake cycles, but they are utterly devoid of conscious mental content. They're awake, but not aware. No cognitive or affective function.
Wait, so if they show any sign of awareness, even if it's inconsistent, what category is that?
That slight shift moves them into a minimally conscious state. Here, the patient shows small, inconsistent, but, and this is key reproducible signs that suggest awareness.
Like what?
It could be a slight, repeatable movement to a command, or maybe tracking someone with their eyes. It requires a really high level of consistent, structured observation to diagnose.
And then there's that deeply challenging, almost cinematic state of locked-in syndrome.
The distinction there is chilling. Locked-in syndrome is caused by a lesion, usually in the pons, and it results in near total paralysis and an inability to speak. The devastating part is that their cognition, their awareness, their memory, it's all intact.
So they're completely trapped.
Completely.
Yeah.
They're trapped inside their body, often able to communicate only through, say, vertical eye movements or blinking. It's a profound reminder that lack of movement does not equal lack of consciousness.
Which reinforces the immediate lesson of this whole section, doesn't it? The level of responsiveness is the most crucial, instantaneous indicator of the patient's overall condition.
Absolutely. And altered LOC is the result, not the disease itself. The causes, like we said, can be neurological, like a head injury, toxicological, like an overdose, or metabolic, like DKA. Anything that disrupts brain cell function will show up as an altered LOC.
So when we're assessing these patients, ongoing structured evaluation is everything. Let's start with a tool we use globally, the Glasgow Coma Scale, or GCS?
The GCS is our objective cornerstone. It scores the patient based on 3 areas: eye-opening, verbal response, and their best motor response. Scores run from 3, which is severe impairment, brain death, or heavy sedation, all the way up to 15, which is fully responsive. And while the total score is vital, it's the individual components that really give us clues about where the dysfunction is.
Beyond just that GCS score, the neuroassessment really zooms in on 2 physical signs that give us a rapid read on deterioration, pupils, and motor posturing.
Let's start with the pupils. Normally, they're round and react briskly to light. As pressure increases or LOC declines, they get sluggish.
Yeah.
In a deep coma, they become fixed and non-reactive. And a progressive unilateral dilation, meaning one pupil gets bigger and bigger, that often means a rapid, dangerous shift of brain tissue is happening.
So one blown pupil is a huge red flag.
A massive red flag. Bilateral fixed pupils suggest more widespread or brainstem damage.
Okay, so if the patient isn't responding to commands, we test motor function with painful stimuli. How do we tell a good response from a bad one?
Consistency is key. You apply the stimulus like firm pressure on a nail bed, and you're looking for the best possible response. A purposeful response is when the patient tries to push you away, or, critically, if they can cross the midline of their body to localize that pain.
And anything less than that is non-purposeful.
Right. And then we get to the abnormal posturing, which the textbook really wants us to visualize. How do we make sure our listeners never mix up decortication and decerebration?
Yeah, this is a classic exam question.
It is. So think of it this way. 1, decortication. This suggests damage above the brainstem. The arms are pulled in towards the core. They're flexed like they're protecting their chest, making a C shape.
C for core. I like that.
Exactly. The legs are extended. It's a severe sign, but it's a bit less ominous than the alternative.
Which is decerebration.
Right, decerebration. This is the sign of more severe damage, often lower down in the brainstem. The arms are extended and rotated outward, away from the core with the wrists pronated.
So it's an exaggerated extension, almost like making an E shape.
Perfect. E for extension. This indicates deeper dysfunction and a much poorer prognosis. And if you get no response at all, that's flaccidity, which is the most severe impairment.
That mnemonic is really helpful. Let's touch on the other diagnostic clues from the physical exam.
Sure. Beyond motor and pupils, we're looking at breathing patterns. For instance, Cheyne-Stokes respiration, those cycles of fast, deep breathing followed by apnea that suggests deep bilateral lesions.
And what about ataxic breathing?
Ataxic respiration is completely irregular in rate and depth. It indicates severe brainstem damage and is usually an immediate precursor to respiratory arrest.
Wow.
We also check the corneal reflex, the gag reflex, the swallowing reflex. If those are absent, it signals a deep coma and a huge risk of aspiration.
So after the physical exam, what are the go-to diagnostic tools to figure out the cause of the LOC change?
For structural problems, you need imaging, and fast. A CT scan is quick and great for spotting a hemorrhage. An MRI gives you more detail for soft tissue, like a tumor. An EEG is critical for electrical activity, especially if you suspect a non-convulsive seizure.
And we can't forget the metabolic side.
Never. Blood tests are mandatory. Check glucose, electrolytes, especially sodium liver and kidney function, osmolality, and of course a toxicology screen. You know, treating profound hypoglycemia can reverse a coma in minutes. Finding and treating a structural cause takes a lot longer.
Okay, let's move to the nursing process, which is just absolutely unforgiving in neurocritical care. Priority number 1 is always the airway. How does the nurse actively prevent that catastrophic aspiration risk in a comatose patient?
Well, when a patient is unconscious, their protective reflexes are gone. The epiglottis, the tongue, the relaxed, and aspiration is highly probable.
So what are the first actions?
It's all about positioning. We elevate the head of the bed, or HOB, to 30 degrees. And if the spine is stable, we use a lateral or semi-prone position. This uses gravity to help the tongue fall forward and lets secretions drain out of the mouth, not into the lungs.
Suctioning is necessary, but the text is very specific about the risks.
It is. Suctioning, while vital, transiently raises ICP and can cause hypoxia. So we have to pre-oxygenate or briefly hyperventilate the patient with 100% oxygen before and after each pass. And keep the suction pass short, under 15 seconds.
Right.
And if the patient is intubated, meticulous oral care is non-negotiable. Moving the tube daily using chlorhexidine mouthwash, it drastically reduces the risk of ventilator-associated pneumonia.
Beyond the physiology, there's safety and dignity. Let's talk about restraints, which can be tricky.
They can be. Safety is mandatory, so we pad the side rails, but physical restraints are often counterproductive. If an agitated patient fights the restraints, the physical resistance causes a dramatic spike in blood pressure, which directly increases ICP.
So we're actually making things worse.
You can be, yes.
Yeah.
We have to prioritize chemical sedation or environmental controls over physical restraints. They often require a specific written prescription to even be illegal.
And dignity in an unconscious patient, what does that look like?
It's a foundational principle. Always assume the patient can hear you. Always. When you're providing care, speak to them. Explain what you're doing, provide privacy, and above all, avoid negative comments about their prognosis within earshot. The nurse is the last line of defense for that patient's humanity.
Let's discuss fluid management. We usually want to hydrate patients, but here the text warns us to go slowly. Why the paradox?
Because every drop of fluid is competing for space inside that fixed skull. 4 fluids have to be given slowly and often in restricted amounts to minimize the risk of increasing systemic blood volume, which would, in turn, increase cerebral blood volume and worsen edema.
It's a constant balancing act.
It is a constant balancing act, and nutritional support needs to be started early within 48 hours via tube feedings. Research shows this improves outcomes.
Immobility brings its own set of complications. What are the key strategies to prevent skin breakdown and contractures?
Vigilance. A rigorous turning schedule every 2 hours is mandatory. And when we turn, we avoid dragging to prevent shearing forces that tear the skin. We maintain correct body alignment with trochanter rolls for the hips and splints or foam boots to prevent foot drop.
And range of motion?
Passive range of motion exercises at least twice a day to prevent permanent contractures. And we often use specialty beds, like low air loss beds, to distribute pressure more effectively.
The eyes are another high-risk area when reflexes fail, aren't they?
Absolutely. If the corneal reflex is absent, the eye can stay open, dry out, and get abrasions. So the nursing care is very detailed. Frequent cleansing with sterile saline, lubricating with artificial tears every couple of hours, and then careful use of protective eye shields.
Okay, let's talk temperature control. There's a quality and safety alert here that's pretty direct.
Yes. The alert says the temperature of an unconscious patient is never taken orally. We rely on rectal, tympanic, or core monitoring. And we treat fever so aggressively because hyperthermia significantly increases the cerebral metabolic rate, which just fuels the cycle of edema and injury.
So what does aggressive fever reduction look like, and what's the one big pitfall to avoid?
It means removing bedding, cooling the room down to maybe 65 degrees Fahrenheit, and using antipyretics. If that fails, cooling blankets. But the single biggest pitfall we have to avoid is shivering.
Why is shivering so bad?
Shivering is a massive physiologic challenge. It causes oxygen consumption to skyrocket. If a patient starts to shiver during cooling, we have to intervene immediately, often with medication, or we risk defeating the entire purpose of the intervention.
And if the fever persists?
Persistent, unexplained hyperthermia could tragically indicate damage to the thermoregulatory center in the brainstem.
Final details here cover elimination.
Right. We have to routinely check the bladder for retention, either by palpation or a bladder scanner. Once the acute phase is over, we prefer an intermittent cath program over an indwelling catheter to reduce the UTI risk. And we manage the bowels proactively with stool softeners to prevent straining, which raises ICP.
As the patient begins to emerge from coma, the focus shifts to rehabilitation. What's the approach to sensory stimulation?
We use a structured program: auditory, visual, tactile, talking to them, playing familiar music. But crucially, as patients emerge, they often go through a period of profound agitation. We have to recognize this not as a negative, but as a positive sign that awareness is returning.
So what's the intervention for that agitation?
It's counterintuitive. The best intervention is actually minimizing stimulation, limiting visitors, keeping the room quiet, one person speaking at a time. We have to prevent sensory overload. And finally, we just can't overlook the crisis the family is in. The nursing staff plays a huge role in counseling them through anxiety, grief, and sometimes the devastating decisions around brain death, the irreversible loss of all brain function. We have to support them through that acute stage of loss.
Moving now to part 2, the absolute nexus of neurocritical care. Increased intracranial pressure. This is where minutes matter, and understanding the core physics of the skull is everything. So define ICP for us, and what's the normal range?
ICP is the pressure exerted by the contents, brain tissue, blood, and cerebrospinal fluid, or CSF, within the rigid confines of the skull. The cranial vault is a fixed box, Normal pressure is 0 to 10 millimeters of mercury, and 15 is generally considered the upper limit of normal. Once you cross that, you're in the danger zone.
To really get the crisis of rising ICP, we have to understand the Monro-Kellie hypothesis. Can you break that down for us, maybe with a simple analogy?
Sure. The Monro-Kellie hypothesis is the fundamental rule. Imagine the skull is a perfectly packed and flexible suitcase. Inside, you have three things: brain tissue, blood, and CSF. The doctrine states that because the total volume has to stay constant, if the volume of one of those things increases,
Like a tumor growing or a bleed.
exactly, then the volume of one or both of the others has to decrease, or the pressure will spike.
So what are the first ways the brain tries to compensate?
It uses two main mechanisms. First, it manipulates the CSF. It can displace CSF down into the spinal column, increase its absorption, or slow down its production. Second, it can decrease cerebral blood volume through mild vasoconstriction.
But that buffering capacity is limited.
Extremely limited. Once those mechanisms are exhausted, adding even a tiny amount of new volume like 5 or 10 ml of blood will cause ICP to skyrocket exponentially. That's the crisis point.
That's a powerful concept. We also need to talk about the link between CO2 and blood flow.
It's a vital, direct link we manipulate all the time. Arterial carbon dioxide, or PaCO2, is the most potent cerebral vasodilator we know of.
So what does that mean clinically?
An increase in PaCO2 causes the cerebral blood vessels to widen dramatically. This pours more blood into the skull, increasing volume and spiking ICP. Conversely, a decrease in PaCO2 through controlled hyperventilation causes vasoconstriction, which limits blood flow and can transiently lower ICP.
But you had to be careful with that.
Very careful. Too much vasoconstriction risks causing cerebral ischemia. You're trading one disaster for another.
And cerebral edema just adds more volume to this whole equation. How does autoregulation fit in?
Autoregulation is the brain's built-in ability to maintain constant blood flow despite changes in systemic blood pressure. Normally, if your MAP goes up, your cerebral vessels constrict to protect the brain.
Right.
But when ICP gets chronically high or there's a severe injury, that critical mechanism is impaired or fails completely. When that happens, the brain is at the mercy of systemic blood pressure, which can lead to runaway edema.
The ultimate metric we're tracking isn't just ICP, it's how well the brain is being perfused.
Right.
And that brings us to cerebral perfusion pressure, or CPP. Explain the calculation and the threshold we are fighting to maintain.
Right, so CPP is the net pressure gradient that's driving oxygen to the brain tissue. It's calculated by taking the mean arterial pressure, MAP, and subtracting the ICP. So CPP equals MAP minus ICP.
And that reveals the central challenge, doesn't it? If ICP is rising, you need a higher MAP just to keep the CPP stable.
Precisely.
What's the critical threshold that requires immediate aggressive action?
The critical threshold is 50 millimeters of mercury.
What?
If CPP falls below 50, you risk irreversible neurologic damage. Our goal in the ICU is often to keep CPP at 70 to 80.
And the absolute worst case scenario.
The point of no return is when ICP equals MAP. At that point, the pressure inside the skull equals the pressure trying to push blood in, and cerebral circulation just stops.
When the brain senses that it's ischemic, it has this frantic last-ditch mechanism. Describe the Cushing's response and how it evolves into the dreaded Cushing's triad.
So the Cushing's response is the brain's attempt to restore blood flow. It signals the vasomotor centers to jack up systemic arterial pressure. Clinically, you see a huge spike in systolic blood pressure, which widens the pulse pressure and a reflex slowing of the heart.
That's the warning siren.
It is. The Cushing's triad is the grave sign of extreme deterioration. It means the brain is actively shifting downward and herniation is imminent. The triad consists of bradycardia, hypertension with that wide pulse pressure, and bradypnea, which is slow, irregular breathing.
If you see that triad, you're out of time.
You are. The shift is happening.
So let's back up. What's the earliest, most sensitive sign of rising ICP, according to our key resources?
The earliest and most sensitive sign, and this is a quality and safety alert, is a subtle change in the level of consciousness. This is why serial neuroassessments are non-negotiable. You're looking for mild restlessness, agitation, increased confusion, or just a noticeable slowing of speech.
And as the pressure keeps mounting,
The progression is predictable. Stupor, where they only respond to pain. Then the abnormal posturing we talked about, decortication, then decerebration, then coma.
and the late, most ominous signs.
The loss of brainstem reflexes. Fixed pupils, no corneal reflex, loss of the gag and swallowing reflexes. Losing those is a sign of imminent respiratory or cardiac arrest.
Beyond herniation, severe neurodysfunction often derails the body's ability to manage water. What are the two specific high-stakes fluid and electrolyte complications we have to watch for?
We have to be hypervigilant for neurogenic diabetes insipidus, or DI, and syndrome of inappropriate antidiuretic hormone, SIADH. Both come from a disruption in ADH, which is controlled by areas highly susceptible to swelling and trauma.
Okay, so DI first.
Neurogenic DI results from a decreased secretion of ADH. Without ADH telling the kidneys to hold on to water, the patient voids massive amounts of dilute urine.
What does that look like?
Extreme. Urine output over 200 ml per hour for 2 hours straight, low urine-specific gravity, and the serum becomes hyperosmolar high sodium. The treatment is replacing the water, electrolytes, and giving synthetic ADH like desmopressin.
And SIADH is the exact opposite.
Precisely. SIADH is caused by increased ADH secretion. The kidneys retain massive amounts of water, leading to volume overload and hemodilution. The key lab finding is dilute serum, sodium hyponatremia, and very little urine output.
And this is where that highly specific treatment protocol comes in, and it's a real tightrope walk.
It absolutely is. The primary treatment is severe fluid restriction, often less than 800 ml a day. But if the hyponatremia is severe, we have to correct the sodium using a concentrated solution, like 3% hypertonic saline.
But you have to do it slowly.
So slowly. The textbook emphasizes the rate must be less than 1.3 MEq per liter per hour. Rapid correction can cause a devastating condition called osmotic demyelination syndrome. You're walking a very fine line to save the brain without damaging it further.
Let's transition to the invasive monitoring systems used to quantify ICP. What's the gold standard and what are the risks?
The gold standard is the intraventricular catheter, or ventriculostomy. It's placed directly into the lateral ventricle. Its advantage is twofold. It gives you a continuous, accurate pressure reading, and it lets you actively drain CSF, which is the fastest way to treat high ICP.
But the risks are significant.
They are. You're putting a foreign object directly into the brain's fluid space. The major risks are infection, meningitis, and hemorrhage. Strict aseptic technique is paramount.
What are the other systems?
There's the subarachnoid screw or bolt, which is less invasive but can lose accuracy if it gets blocked. And fiber optic monitors, like the Licox system, which use a transducer-tipped catheter. But regardless of type, strict asepsis is non-negotiable.
The monitor doesn't just give you a number, it shows a waveform. Let's talk about the crisis waveforms, specifically the A waves.
Yes, interpreting the waveforms is critical. The most significant are the A waves, or plateau waves. Imagine the pressure readings suddenly spiking from 20 up to 80 or 100 and just staying there for 5 to 20 minutes.
That sounds terrifying.
It is. These spikes are not benign. They signal compromised cerebral perfusion. They're a red flag for imminent herniation risk. B and C waves are less ominous, usually related to respiration or blood pressure fluctuations.
And quickly, there are newer monitors that go beyond just pressure, right?
Yes. Invasive monitoring is moving towards measuring cerebral oxygenation directly. Tools like the Licox catheter can be inserted into brain tissue to measure oxygen partial pressure, alerting you to impending ischemia much earlier than just a lagging ICP number.
When ICP is rising fast, management is all about speed. Decrease edema, lower CSF volume, and decrease blood volume, all while desperately trying to maintain CPP. What are the key pharmacologic interventions?
The first line of defense is osmotic diuretics. Mannitol and hypertonic saline work by creating an osmotic gradient that pulls fluid out of the brain cells and into the blood vessels to be excreted. This requires really close monitoring of serum osmolality and urine output.
And corticosteroids.
Corticosteroids like dexamethasone are used specifically to target edema around brain tumors, but, and this is a key distinction, they are generally not indicated for trauma or stroke-related edema.
We talked about fever. Why is temperature control considered an ICP intervention, not just reading an infection?
Because temperature is a metabolic lever. Every degree of fever significantly increases the brain's metabolic demand, which accelerates inflammation and edema. So aggressively preventing fever while strictly avoiding shivering is a direct strategy to reduce the metabolic burden on the brain.
How do we navigate that tension between maintaining CPP, which needs a high MAP, and restricting fluids to fight edema?
That's the crux of neurocritical care. We often need to keep MAP high enough for a CPP over 70. If fluid restriction prevents that, we have to use vasopressors, like norepinephrine, to squeeze the blood vessels and artificially raise the MAP without adding more volume. It's a constant, calculated titration.
And when medical interventions fail, you might induce a barbiturate coma. Explain the trade-off there.
A barbiturate coma is an extreme measure. The drugs, like pentobarbital, drastically reduce the brain's metabolic rate, putting it into a deep chemical rest. The trade-off is profound. You completely eliminate your ability to do serial neuroassessments.
You're flying blind.
Essentially, it requires continuous advanced monitoring, ICP, EEG, cardiac, because the clinician has blinded themselves to the patient's subtle responses. Surgically, a decompressive hemicraniectomy, removing a piece of the skull, is the last resort to give the brain space to swell.
Okay, let's pivot to the specialized nursing interventions. The things the nurse does every minute to optimize perfusion, starting with positioning.
Positioning is an active intervention. The patient's head has to be kept in a neutral midline position, often with a cervical collar, to prevent kinking the jugular veins.
Which are the primary outflow tracts for blood leaving the skull.
Exactly. The HOB has to be elevated 30 to 45 degrees. And crucially, we have to avoid any extreme neck rotation or flexion. That compresses the jugulars and immediately raises ICP. We also avoid extreme hip flexion, which increases intra-abdominal pressure. And here's the practical difficulty. Even just turning the patient can cause a dangerous spike. It has to be done gently, slowly, and you have to watch the monitor. If ICP spikes above 25 or doesn't return to baseline quickly, the intervention was too disruptive.
You mentioned the Valsalva maneuver earlier. How do we prevent that?
The Valsalva maneuver straining, holding your breath coughing, causes a massive spike in ICP. We teach alert patients to exhale when moving, we give stool softeners, we manage suctioning carefully, and we strictly avoid clustering our nursing activities.
Spacing things out.
Yes, don't do the bath, the turn, and the suctioning all at once. You're subjecting the brain to a sustained period of high pressure. You have to space out those high-impact moments.
And a final note on infection control with these monitoring systems.
With any invasive monitor, especially the intraventricular catheter, the infection risk is huge. Strict aseptic technique for dressing changes, connections, transducer manipulation, it's all non-negotiable. And we're constantly monitoring for signs of meningitis, like an unexplained fever or neutral rigidity.
Our third section moves us into the world of procedures. We're talking craniotomy, craniectomy, and cranioplasty. And the most intense nursing focus has to be on the differences in post-op management based on the surgical approach.
Yes, we have to be able to differentiate the care based on location. There are three main approaches, each with its own strict positional rules.
Okay, what's the first one?
Number one, the supratentorial approach. This is for structures above the tentorium like the frontal or temporal lobes. The incision is usually behind the hairline. Post-op nursing rule. HOB must be elevated 30 degrees, neck neutral.
And can they lie on the operative side?
They can lie on either side or their back unless a large tumor or bone flap was removed. Then we avoid the operative side to prevent pressure on that site.
Okay. Number two is the infratentorial approach, or posterior fossa. This is the high-risk approach near the brainstem.
It is, and here the absolute priority is keeping the neck in straight alignment and strictly avoiding neck flexion. If the patient looks down at their chest, that tension can tear the suture line.
So what's the positioning?
They're initially kept flat on one side, completely off their back, to keep the neck neutral and prevent compression.
And the third approach is transsphenoidal.
Right. This goes through the mouth or nasal sinuses, usually for pituitary tumors. The challenge here is the proximity to the airway.
So what are the rules?
HOB is elevated, and the patient have to be taught to avoid anything that increases pressure in the sinuses. No nose blowing, no coughing, no sneezing, and critically, no sucking through a straw for up to a month. Any of those can cause a CSF leak.
What's the preoperative medical management look like?
A lot of diagnostics to map the surgery, CT, MRI, maybe a cerebral angiogram. And medications are used prophylactically. Prophylactic anticonvulsants like phenytoin are common because surgery itself is a seizure trigger. Corticosteroids are started to shrink tumor-related edema, and osmotic agents like mannitol might be given right before the incision to start reducing brain volume.
You know, the source mentioned that routine use of anticonvulsants is debated. Why the controversy if the seizure risk is high?
That's a great point. While the risk is high, the debate is about the side effects versus the benefit for all patients. Some studies suggest the risk of toxicity or drug interactions doesn't always outweigh the benefit of preventing one potential seizure. So many practitioners individualize it now.
And finally, what's the crucial preoperative nursing management?
The baseline is everything. We establish a comprehensive neuro baseline, LOC, motor strength, any speech deficits, because these things might be temporarily worse post-op due to swelling.
And patient education.
Vital. Preparing them for the bulky head dressing, the periorbital edema, their eyes swelling shut, and establishing a clear communication plan for when they're intubated and can't speak.
Okay, post-op care is a sprint against swelling and bleeding. Let's start with controlling that inevitable cerebral edema.
Edema control is paramount. We know swelling peaks between 24 and 36 hours post-op. That's the most dangerous window.
Right.
So we continue the positioning strategies we discussed, and we administer tapered doses of dexamethasone and intermittent mannitol to aggressively pull fluid out of the brain during that critical period.
How is pain managed? And what about seizure stability?
Headache is nearly universal. We manage it with acetaminophen, maybe moving to codeine or morphine, and we continue monitoring serum levels for anticonvulsants if they're prescribed to keep them in the therapeutic range and ward off seizures.
Let's focus on acute, life-threatening complications.
Wow.
What is the single most urgent sign of deterioration? The one that means the patient has to go back to the OR immediately.
This is a quality and safety alert, and it cannot be overstated. Any unexpected failure to awaken, a sudden drop in LOC, or the appearance of a dilated pupil on the operative side must be reported immediately.
Why that pupil specifically?
A fixed dilated pupil strongly suggests an intracranial hematoma is rapidly expanding, crushing the third cranial nerve on that side. It requires an immediate return to the OR for evacuation to save the patient's life. We also maintain that vigilance for DI and SIADH. And because many of these patients are on high-dose steroids, we have to monitor their blood sugar every 4 to 6 hours, as steroids can cause severe hyperglycemia, which worsens edema. H2 blockers are also needed to prevent stress ulcers.
What about the risks and signs of a CSF leak, which can lead to meningitis?
A CSF leak is a crisis. On addressing, we look for the halo sign, a blood stain ringed by clear yellowish fluid. But it can also show up as a clear sudden discharge, a persistent salty taste, or fluid from the nose or ear. This is a direct line for infection into the meninges. The patient has to be taught to strictly avoid coughing or blowing their nose. And finally, because of the immobility, we actively manage VTE risk with routine turning, passive ROM, and prophylactic heparin and anti-embolism stockings.
We're swing focus now to a cluster of other common neurologic dysfunctions, starting with acute confusion, delirium.
Delirium is defined as an acute confusional state, and the key descriptor is its fluctuating course and acute onset. It's a major crisis in critical care, affecting up to 80% of ICU patients, and it triples the risk of in-hospital mortality. We have to see it as acute brain failure.
What are the main culprits we can change?
The major modifiable risk factors include the overuse of certain meds, especially benzodiazepines, and surprisingly, blood transfusions.
How does the confusion assessment method, or CAM, help us distinguish this from dementia?
The CAM is crucial because we have to differentiate delirium from dementia. Delirium is rapid, acute, and often reversible if we treat the cause like an infection or a drug reaction. Dementia, on the other hand, is a slow, chronic, irreversible decline, with Alzheimer's being the most common form. The CAM helps us spot the acute fluctuations and inattention that define delirium, and prevention is the highest priority. This means frequent reorientation, making sure patients have their glasses and hearing aids, optimizing sleep, early mobilization, and being really judicious with sedatives.
And what about pseudobulbar affect? It sounds like a difficult emotional issue.
It's often misunderstood. Pseudobulbar affect is where patients have inappropriate or exaggerated emotional expression like uncontrollable bursts of crying or laughing that don't match their actual mood.
So it's a structural issue.
It is. It's from damaged pathways after a stroke or with MS or ALS. The outbursts are highly disruptive, but they are treatable with medication.
Okay, let's move to seizure disorders. Define a seizure and how that leads to the diagnosis of epilepsy.
A seizure is a transient episode caused by abnormal excessive electrical discharge of neurons. Epilepsy is a chronic disorder defined by having at least 2 unprovoked seizures more than 24 hours apart. We classify them based on origin. Focal onset, starting in one area, or generalized onset, which engages networks across both hemispheres, like a generalized tonic-clonic seizure. The causes are vast structural, like a tumor, genetic, or metabolic, like hypoglycemia.
Describe the generalized tonic-clonic seizure, the one most people visualize.
It has 2 stages. The tonic phase is intense rigidity of the entire body, often with the epileptic cry as air is forced out. This is followed by the clonic phase, which is the rhythmic, alternating muscle contraction and relaxation.
And afterwards?
Incontinence and tongue chewing are common. The seizure resolves into a deep unconscious post-ictal state with confusion, drowsiness, and profound fatigue that can last for hours.
The nursing management during and after a seizure is all about safety. Outline the absolute safety priorities, especially the things we must not do.
Okay, during the seizure, provide privacy, ease the patient to the floor, protect the head with a pad, and loosen any constrictive clothing. The absolute do-nots are critical. Never try to pry open clenched jaws or put anything in the mouth. You can break teeth or cause aspiration. And never try to restrain the patient. The contractions are too strong, you can cause injuries.
So what do you do?
If you can, gently position them on their side to help saliva drain out. After the seizure, keep them side-lying, suction if needed, and reorient them when they wake up. And the nurse has to be a meticulous documenter.
Right.
What happened before, the first action of the seizure, the type of movement, and the postictal state.
Long-term epilepsy management is all about pharmacology. What's the goal?
The goal is control, not cure, with minimal side effects. Medications like carbamazepine, phenytoin, levetiracetam are tailored to the patient. And monitoring is essential because many of these drugs have a narrow therapeutic window.
Right.
So we have to check serum levels. And strict medication adherence is the #1 teaching point. Stopping suddenly can induce severe seizures.
What about non-pharmacologic strategies?
Patients have to avoid known triggers: alcohol, stress, sleep deprivation, flickering lights. The ketogenic or modified Atkins diets, high fat, very low carb, have proven effective for some refractory seizures, especially in kids.
And if medication fails?
For some patients, surgical resection of the seizure focus is an option. Beyond that, there are implanted devices like the vagal nerve stimulator or the responsive neurostimulation system, which can sense and abort a seizure before it even starts.
And the final topic here is a critical emergency. Status epilepticus.
Status epilepticus is a medical emergency, a seizure lasting 5 minutes or longer, or serial seizures without regaining consciousness in between. It's a profound metabolic catastrophe.
What?
The brain is burning through oxygen and glucose, leading to hypoxia, acidosis, and irreversible brain damage.
So the goal is to stop it fast.
Immediately. Stop the seizure and ensure oxygenation. This means immediate IV benzodiazepines like lorazepam or diazepam, followed by a loading dose of a long-acting drug like fosphenytoin. And you have to monitor respiratory and cardiac function closely because the meds themselves are powerful depressants.
Our final major section covers headaches or cephalgia, often seen as minor, but they can be symptoms of profound issues or disabling disorders themselves.
We categorize them as primary, no organic cause, which includes migraine, tension type, and cluster headaches, and secondary, which are a symptom of something else like a tumor or meningitis. A specific concern in older adults is cranial arteritis, an inflammation that requires immediate steroids to prevent vision loss.
Can you describe the current understanding of migraine pathophysiology?
It's rooted in a theory called cortical spreading depression. It's a wave of electrical depolarization across the brain that activates inflammatory neuropeptides, especially related to serotonin. This process triggers vascular changes and ultimately severe pain.
And triggers are key.
Yes. Hormonal shifts, foods high in tyramine like aged cheese and red wine, stress, and poor sleep.
Migraines are described in 4 phases, though many people skip the aura phase. What are they?
1, the premonitory phase, hours or days before, with subtle changes like depression or food cravings. 2, the aura phase. In about 30% of patients with focal neurologic symptoms, usually visual flashing lights, zigzag lines. 3, the headache phase. Severe, incapacitating, throbbing pain, often with nausea and extreme sensitivity to light and sound. And 4, the postdrome phase. The pain subsides, but the patient feels exhausted and weak.
Management is dual, abortive and preventative. Let's focus on the abortive treatments for an acute attack.
For moderate to severe attacks, the first-line meds are the triptans, like sumatriptan. They cause cranial vasoconstriction and reduce inflammation. The critical safety alert here is that triptans must never be given to patients with ischemic heart disease or uncontrolled hypertension.
Because their vasoconstrictive effect is widespread.
Exactly. It could trigger a heart attack or stroke. They also can't be taken with ergotamine preparations. Ergotamines are an older class that also cause vasoconstriction. And for the specific excruciating pain of a cluster headache, the acute treatment is often 100% oxygen by face mask or subcutaneous sumatriptan.
And long-term prophylactic strategies.
If attacks are frequent, we move to preventive meds taken daily, like beta blockers or certain antidepressants. The non-pharmacologic strategies are mandatory, trigger avoidance, regular sleep and meal schedules, and keeping a headache diary. And for cranial arteritis, treatment must start immediately with high-dose corticosteroids to prevent irreversible vision loss. So, to recap this comprehensive deep dive, we began by establishing that neurocritical care is a fight on 2 fronts: structural integrity and homeostatic environment. We move through the precise assessment of LSC, understanding the critical differences between all those unresponsive states. We detailed the absolute physics of the brain, defining the Monro-Kellie doctrine, calculating CPP, and recognizing the legal signs of Cushing's triad and A-wave crises.
We then differentiated the complex life-saving positioning and management for neurosurgical patients, the unique demands of supratentorial versus infratentorial approaches, and identified the emergency signs of a hematoma and CSF leaks. Finally, we covered the vigilance required for managing seizures, including the catastrophe of status epilepticus and the dual approach for managing incapacitating headaches.
The unifying theme across every single section is the sheer sensitivity of the brain and the imperative of speed and precision. The ability of the nurse to recognize a subtle change, to enforce correct positioning, to manage fluids. These things are the difference between recovery and permanent damage.
That level of vigilance, especially given how quickly compensation fails, is truly humbling. So as you integrate this, here's a final provocative thought. Given the sensitivity of ICP to even minor physical stress, a cough, a turn, a minute of shivering, what must the neurocritical care team accept but the nature of their patient's environment? How must the entire rhythm of the unit, from physician orders to custodial cleaning, be redesigned to meet the absolute standard of minimal viable stimulation for this unique patient population?
That's a deep question to guide your future practice as you stand as the vigilant protector of cerebral perfusion and brain integrity. Thank you for joining us on this critical deep dive into neurologic dysfunction management.